Welcome, my name is David Moeller, and I present to you today this pilot study, retrospective correlation of test-bolus injection delay time during contrast-enhanced MR angiography in the heart function. Acute limb ischemia has a critical time interval of 6 to 12 hours where limb and tissue-saving procedures can be performed. MR angiography is often used as the diagnostic tool to manage these patients. In order to create evidence that helps with the risk stratification for these procedures, we created a database that correlates the test-bolus delay time of the contrast material, also mentioned as time to peak, with heart function parameters. The test-bolus protocol consisted of cardiopulmonary as contrast agent. Depending on the patient's clinical status, the bolus volume and flow were adjusted accordingly. Parallel to the contrast material injection and flush, MR images of the region of interest were acquired in a 1-second interval for a period of 60 seconds. The picture demonstrates the level of the infrarenal aorta, which defined the region of interest. This way, we created signal intensity curves over time and calculated the TTP value, as we can see in the graph. In total, we reviewed 248 examinations and documented the TTP, flow, bolus volume, and IV line location. From these 248 examinations, 123 patients had a structured heart examination in form of heart ultrasound, heart scintigraphy, or heart MR examinations and were analyzed in greater detail. The average time between heart examination and MRA was 14 days. Patients with changes or major cardiac events between the examinations were excluded from the study. As parameters for the heart function, we used the ejection fraction, MET score, Lee index or revised cardiac risk index, and the presence of atrial fibrillation. The MET score is an equivalent to the NIHA classification, as we can see on the table on the right. The Lee index evaluates the risk of major cardiac events during general anesthesia in relation to comorbidities like congestive heart failure, chronic kidney disease, diabetes, and ischemic heart disease, shown in the table bottom right. First, we'll look at the results of these 248 examinations. The distribution of the TTP values can be seen in the bar chart below. Our population had a TTP mean of 31.17 seconds with a standard deviation of 7.3 seconds. We found a significant difference in mean TTP between flow rates with the ANOVA test. The box plot demonstrates the distribution of the flow rates. The bolus volume ranged between 0.5 to 2 milliliters and showed no difference in mean TTP. The most frequently used bolus volume was 1 milliliter. Comparing the IV line location, we found no significant difference in mean TTP apart of the left cubital and the right hand. Now we look closer to the subgroup of 123 patients that had a structured heart examination in close time interval to the MRA examination. This population had an average of 71 years of age and a BMI of 26.8. Almost half of all indications of these examinations were peripheral artery disease. Together with acute limb ischemia, they covered 2/3 of all indications. The correlation coefficient between TTP and ejection fraction is minus 0.476 and significant. On the right, we can see the scatter plot, which shows a fairly weak coefficient of determination with 0.23. By separating the population into the officially used heart failure classification groups with heart failure with reduced, mid-range, and preserved ejection fraction, we could show significant differences in mean TTP. Although not all patients suffered from heart failure, we simply used these cutoff values as group parameters. Interestingly, almost no TTP value under 30 seconds fell into the group with ejection fraction under 40. The correlation between TTP and ASA-classification is a significant finding, but with a coefficient of 0.2 not a strong one. The mean TTP does not differ significantly between the ASA groups. But interestingly, almost all patients with a TTP over 40 fall into the ASA-4 classification. The Lee index and MET score did not show any significant correlation or differences in mean TTP values. Finally, we compared patients that presented with or without atrial fibrillation. The group with diagnosed atrial fibrillation showed a mean TTP of 36.7 seconds and was significantly longer compared to the 30.6 seconds in the group without atrial fibrillation. We conclude that all information collected during MRA should be stored and made accessible for evaluation of heart function. Despite an inhomogeneous population, we could demonstrate a significant correlation between the time to peak and the ejection fraction and ASA-classification. We suggest that the TTP over 40 seconds is likely to be an ASA-4 classification, and patients with a TTP under 30 seconds are unlikely to have an ejection fraction of under 40. To promote this discussion, I encourage listeners to consider how we can use test-bolus data in clinical routine, and if there should be a standardized method for test-bolus injections, acquisition, and evaluation to collect international comparable data. How much value can we find in other contrast material injection methods used in the clinical routine? And finally, how we can create stronger evidence to make this data clinically applicable. Thank you for your attention.